So thank you all for joining tonight. This is our Survivorship Echo, and Tracy's going to pop our slides back up so we can do a little bit of our intro, and we'll wait till we get into presentation mode real quick. Here we go. We call Tracy Oz, so if you need anything, don't hesitate to reach out to her. Or do you want me to put it? There you go. Great. Thanks, Tracy. So this is our June series. We are back to the Cancer Survivorship Series. We did our COVID and cancer during April. So if you missed any of those, you can go back to the Masonic Cancer Alliance website, and all of our echoes from our genetic series and our survivorship series are all available on the Masonic Cancer Alliance website. Just to remember, I'm Jen Klemp. I know most of you on here. There's a couple numbers I don't, so we'll check in with you during our check-in. And we are very lucky tonight to have two special guests, Dr. Jill Hamilton-Reeves and Dr. Megan Clark. And Dr. Hamilton-Reeves, why don't you introduce yourself, tell us a little bit about who you are and what you do, and then we'll have Dr. Clark introduce herself.
Great. So I have a nutrition discipline background, and I lead clinical trials looking at nutrition strategies to help patients either prevent, fight, or recover from cancer.
Great.
And I'm also a co-director of the Nutrition Shared Resource at KU Cancer Center.
And you also have a degree in exercise physiology. So you never say that, but you do. So
yeah. I'm sorry, I don't say that. Yeah, my undergraduate was in exercise science, and then my PhD is in nutrition. And yes. Yeah, it's interesting when people think one field goes without the other. Synergistic. So I'm glad that we have this talk tonight with both Megan and myself.
Yes, and you are a good example of diet and exercise. You are you live the life, so you inspire us.
I'm a triathlete, so I'm kind of obsessive about it, actually.
All right, Dr. Clark.
Megan Clark. I instead lead the do as I say and not as I do lifestyle, but I am a part of the cancer team and working with the rehab portion of it. So as we'll talk a little bit about tonight, what does that mean for our cancer patients? Because they are still athletes and parents and workers and caregivers. So really being able to help them kind of get the most out of life and in the recovery process through this journey.
Yes, and we are very lucky to have these types of specialists in our backyard. And I tend to be more like Dr. Clark, where I actually kind of dream that I'm this like physically fit specimen. So if I dream it, I will become it.
That's right.
That's right. All right, so let's move ahead. And Tracy, it looks like I don't have my little arrows anymore. Do you want to go ahead? You can, there we go. There we go. So tonight we will cover just a little bit of housekeeping, and then we'll jump into our topics, which you kind of heard a little bit about. And then we'll just review our upcoming sessions and some homework and wrap up. All right, next slide. Are you able to move? Because I can't move them. What if you just click like? Uh-oh, we're frozen. All right. There you go. There we go. Your continuing education credits, whatever your discipline is, you will receive some credits with your physician, nurse, advanced practice provider, social worker, or dietitian. And on the next slide, we will show you our disclosures. Everyone is free of disclosures except myself. So if you have any questions, feel free to reach out about my disclosures. Next slide. And here's how you get your continuing education credit. You have 3 different ways: text, go online, or use the app. And if you don't have the app, you should have the app, because you can sign up for other classes, and that is where you can track all of your credits. It's 97 deny is the code for tonight, and you have a week to get yourself registered. Next slide. And we want to thank our sponsors, of course. This is through a cooperative agreement from the Centers for Disease Control and Prevention, as well as the KU Cancer Center and the Masonic Cancer Alliance, plus our wonderful ECHO team that most of you have gotten to know. Next slide. So now we're going to do our check-in, and this is a group of, we list everybody who's registered, but we do want to go through, there's some new folks on here and there's some phone numbers, just to make sure that we are saying hi. And as most of you know that have participated in ECHO, it's all about building a community. And we really have a great community across all of Kansas and Western Missouri, plus folks from across the country. So we want to make sure that as we build this community around survivorship, that we have the opportunity to get to know each other. I know that some folks have been able to reach out to each other even after some of these ECHO sessions, and some of you reach out to those of us on the team, and we're able to connect you with resources or to each other. So we want to continue to encourage that. So Tracy, do you want to pop us up to everybody, and we'll just kind of go through, and we'll have some people say hi. Some of you've put your name in the chat box, so please do, if you are on, put your name and anything specific we need to know about you in the chat box. And you heard from our speakers. How about Carla? Do you want to say hi? Carla with a C, because we have two Carlas on. There you go.
Oh, good afternoon from Olathe Cancer Center.
Great. Great to see you, Carla, or hear you.
Yeah.
There you are.
Good to see you.
We appreciate you joining us, and we love your input. So thanks for joining us.
Thank you.
And then Deborah, how about Deborah? Do you want to say hi?
Hi, this is Deborah Edelman-Dolan from Stormont Vales Cancer Center in Topeka.
Great. Good to hear from you tonight. Thanks for joining. And Denise is back from Hayes. Do you want to say hi, Denise? Oh, she's muted. We'll unmute you. Well, there we go.
From
Hello.
Hayes. I'm a little technologically challenged, okay?
Doing great. Do you have anyone with you tonight? Is anyone there with you tonight?
No, it's just me, myself, and I.
All right. Well, thanks for joining. We appreciate it.
Okay.
All right. And Jan, do you want to introduce yourself?
Hello, everybody. I'm Jan Lyon, and I'm with the KUMC Project ECHO. And do I get points because I did walk around the building before this started?
Yes, you did your pre-homework, your prehab, as we'll learn about. All right. And also from the ECHO Institute, locally, our ECHO Hub. Dr. Wright, do you want to say hi?
Hi, I'm Shauna Wright. I'm the Associate Director of KU Center for Telemedicine, and it's great to see you all tonight.
Great. Thanks for joining. How about Lainey? Or Leanne. I'm sorry. Why did I say Lainey? There you go. My phonics is bad tonight. Leanne. There we go.
Hi, I'm Leanne from Advent Health, Shawnee Mission.
Great. And Leanne, what is your role at Advent Health?
I do patient navigation for head, neck, and lung cancer patients.
Great. Well, some of the stuff you'll learn about tonight, or we'll talk about tonight, directly relates. So thank you for joining us. And sorry, I mispronounced your name.
That's okay. Thanks for having it.
You bet. Molly.
Hi, I'm Molly. Hi, Jill. I am the physical therapist at the Cancer Center at Shawnee Mission Advent Health. And so I do all of the prehab and rehab and everything there. So
awesome. Well, great to have you. All right. How about Rebecca?
Hi, guys. This is the cat lady.
Yeah.
I work for the Kansas Healthcare Collaborative as a quality improvement advisor, and I'm helping multiple clinics and hospitals with multiple projects dealing with diabetes, hypertension, cancer, and just about anything you can think of.
Great. Well, good to have you. And we appreciate you taking care of all those cats out there. So thanks for doing that. All right. How about Hope?
Hi guys, it's Hope Crable with the Masonic Cancer Alliance. Great to see everyone today.
Great. And Trish?
Hi everybody, I'm Trish. I'm part of the ECHO team.
Great. And Michelle? No? Maybe not. Maybe that's still on mute. That's okay. How about Mary Beth? Do you want to say hi?
Sure, I'm Mary Beth Warren, and I'm with KU Med Center's Area Health Education Centers.
Great, thanks, Mary Beth. And Michelle has no microphone or camera. No worries. We are glad to have you any way you come. And then I introduced Tracy. Tracy, do you want to say hi so everybody knows who you are?
Hi, everyone. I'm Tracy McCarty. I'm with the ECHO team.
Great. All right. So did I miss anyone except Dr. Barr, who usually only says hi in the chat box, but maybe she wants to chime in tonight. She may have us muted. That's okay. Dr. Barr is also on from Lawrence, so we appreciate her joining in. Okay, so back to our slides. And we're going to let Tracy drive tonight. Okay, great. Thanks, Tracy. Great. So we do record our sessions, and as we talked about, just make sure that if you miss a session or if you want to go back to one of the earlier topics, they're all available on the Masonic Cancer Alliance. And if you're uncomfortable with that, obviously you can you turn your camera off. But as you'll see from the next slide, we really would love the fact that all of you are on tonight and using your cameras. We want you to be, that's how we get to know each other. That's how we are engaged. And I think we're all getting so used to seeing each other and our pets and everything else as we talked about that we really do appreciate you using your cameras. And next slide, as you know, we use polls. So we are going to start by asking a poll, and anytime you see that, we're going to do a combination tonight, both of standard polls. We go answer sort of yes or no or choose the best answer. And then we're also just going to direct you to answer some in the chat box. And this is really helpful. It helps us sort of understand kind of where you are, and it helps our experts also know kind of the resources or the tools that maybe you're already using or obviously not using, and that way we can sort of focus on that information. So next slide will be our first poll. And do you currently have a formal process for nutrition assessment at your organization? And Tracy's going to pop up the poll and answer yes, no, or unsure. Great. All right. Most of you voted. Go ahead. We can end the poll, Trace. Here we go. So some of you, yes, some of you are unsure. So I think the interesting part about nutrition assessment is as we talk about survivorship and as Dr. Hamilton Reeves kind of goes into her education for us tonight, we will learn why this is such an important tool and an important process for us to have. All right, next slide. So the reason that we want to bring the topics together that we're focusing on tonight is because we know that survivorship really is a comprehensive multidisciplinary approach. And we've had some topics so far this session dealing with cardio-oncology, distress screening, tobacco and smoking cessation. So when we think about our needs of survivors, part of what we have to do is really understand which disciplines are needed. When do we need to refer to someone outside of the clinic? And I think the next slide really helps us identify through risk stratification. Oh, I deleted a slide, but that's okay. We'll just stop here. That's okay. Is the need for risk stratification. So we know that every patient doesn't need the same level of intervention and the same level of support, but we only know that if we're asking questions and doing assessment. So I think as we tee off tonight, we really think about what is the patient's biggest risks. That's where, like we heard from Rebecca, we have patients who are dealing with hypertension, diabetes. Our patients are not without comorbid conditions. So as we put them into perspective and we really think about how to best manage our patients, I think the two topics tonight are in tandem, that really none of our patients are exempt from lifestyle, right? So whether we're talking about diet and exercise, whether we're talking about really focusing on some of those limitations that they experience both before their diagnosis and after, these are things that pretty much are universal for our patient population of cancer survivors. So I think that as we dive into this, don't hesitate to ask questions, to obviously share some best practices, and we will tee it up for Dr. Hamilton Reeves to take over from here.
Great, thanks, Dr. Klim. yeah, everybody eats and everybody moves. So the topics tonight are definitely relevant to all of the patients that you see. And I'm excited that there's so many different disciplines that are joining in tonight. So I'm looking forward to your questions and comments. So starting out, just kind of giving some framework of what my lab does. We essentially test different nutrition strategies to see if we can unlock the potential of nutrition to improve outcomes, survivorship, and quality of life in cancer patients. And that's really our mission. It helps us decide what projects are aligned with our goal. That's how we know our purpose and what to do. Next slide. Or can I advance the slides? I'm sorry, I didn't ask if, do I advance the slides or do you? It advanced, which is great.
It's we all are co-hosts, but for some reason I wasn't able to advance it, but maybe you can. So if you see the little arrow lit up at the bottom left, then you'll be able to.
No arrow, so I will just use the next slide if
So
Oz doesn't mind helping me. Okay, thank you. So no, just to kind of frame the relevance of the topic tonight, I work with a lot of surgical patients, and I know that many of you work with other cancer treatment modalities. So cancer or surgery and chemotherapy in particular are linked to muscle loss and malnutrition. And what's important about that is that malnutrition, which feeds into sarcopenia. Sarcopenia is a term for low muscle mass and low muscle function, whether that's strength or performance. And malnutrition, of course, you need good fuel in order to keep your muscle. So it's kind of related to sarcopenia. But both of those conditions are associated with negative outcomes. And as Dr. Klemp mentioned, really looking at our processes to screen, identify, diagnose, monitor patients is important to look at periodically. So I saw in the poll that many of you said no, many of you said unsure. And it's likely you do have a process in place, and yet asking and being curious about the question of how effective is that process? How many patients have you seen come to you where you have a suspicion that they've been missed, and why was that? What did that look like? So hopefully some of the things that I bring up today will help pique your curiosity and lead to some conversations at the different institutions and places that you all work. So I'm going to talk a little bit about painting a picture of what would be ideal regarding how integrating screening and assessment can help improve outcomes and what that would look like, and some of the data from our research studies. Next slide. So I mentioned sarcopenia. Again, that's defined as low muscle mass and function. And this is a condition that has been getting more and more attention because of all of the research and the evidence that's building showing poor outcomes from cancer treatments in patients that are sarcopenic. And to keep in mind that sarcopenia is something that you likely will see as a person ages. Our intake changes, sometimes because of dentition, sometimes because of socioeconomic factors. There's a lot of things that affect our appetite as we age and could lead to lower muscle mass. Also, many times we become less physically active. And even if we are active, there's physiology working against us regarding hormone levels and also the way that the muscle fibers respond to exercise as we age. And as I mentioned, the hormonal shifts with age, lower testosterone, usually lower estrogen, those are, again, like a physiology that work against us as far as keeping lean mass on easily. And that doesn't mean that there aren't things that we can do about that. And Dr. Clark will mention those things. But I think it's just important to note that without trying, these are the things that would naturally happen. In addition to that, the disease, having cancer on board, releases many different factors that are going to lead to muscle loss, such as higher inflammation and then also some tumor-related factors. In addition, we have many patients that come with comorbidities such as diabetes, and having unhealthy insulin levels can also affect muscle mass and strength. So I think all of that kind of paints a picture as far as thinking about the patients that come to you newly diagnosed with cancer. And the evidence to date suggests that half of the patients that we face right as they are facing a new diagnosis of cancer, half of them are sarcopenic coming in to see us. Next.
And Dr. how do you diagnose that? Is that a clinical diagnosis? Do you need to throw someone on a DEXA? Like, how do we identify that?
Yeah, so we just wrote a review paper about that, actually. And there's lots of different ways to identify that, and it really depends on the resources at the facility. So essentially, you need to have 2 of 3 of the aspects of the diagnosis of sarcopenia. So there is a billing code for it, which is helpful. And the 3 factors are muscle mass. So you could use CT scans, you could use DEXA, you could bioelectrical impedance analysis. There's lots of different ways to measure body composition. So that's one of them. The second is muscle strength, and the third is functional strength. And so there are assessment tools where you can visually look at someone as far as where lean mass will be. You can do like a sit to stand for a physical function. You could do hand grip strength for muscle strength. So there are some quick and easy tools that can be used. And perhaps another helpful toolbox thing that, now that you asked that question, that I should send you is the review paper that we wrote about what this would look like. Yeah, yep. Sorry I didn't send that ahead of time.
I think it's great also, and Dr. Clark, if you want to chime in there too, feel free. I think having those codes for sarcopenia is also very important, because the more we can incorporate into obviously billing, and as we think about whether it's a survivorship visit or when you're onboarding a patient, we know that you can bill for psychosocial assessment. We can bill now for assessment of sarcopenia, and these are, I think, really important, because the only way that we tend to integrate in these new practices is to be able to bill for them. So that's a really important piece of the pie.
Right, which adds value to the multidisciplinary nature of caring for the patient with cancer. So yeah, good point. Thanks. Next slide. So one thing that comes up is the difference between sarcopenia and cachexia, because there's obviously going to be some overlap here, that we could have some patients come to us with sarcopenia, and then as their disease progresses, it could transition into pre-cachexia, cachexia, and then refractory cachexia. So to help simplify this, both are inflammatory related conditions. Cachexia is much more severe and is driven more by the disease process itself. So by the physiology of cancer or HIV, or sometimes heart conditions can also drive cachexia. Both will have the features of loss of muscle, and both will lead to disability and diminished quality of life, frailty and mortality. And so this can be on a continuum, or they can be distinct, and then they kind of get worse as the disease progresses. Next slide. So I think it's helpful to really just start with the problem, as far as what's the research that my lab focuses on, and then also thinking about potential gaps or problems at your institutions that you could be curious about. So the first 3 bullets are really specific to the population that I've been working with. So our biggest study that I'll talk a little bit about today is a national trial where we're looking at patients that are getting their bladder removed for their cancer treatment. And it's called a cystectomy, and the procedure has incredibly high complication rates. So 2 out of every 3 patients will have a graded complication. So a pretty major complication. 1 in 4 will develop an infection. One of the clinical features that you see in this patient population is, 2 weeks after their surgery, they come back to see the physicians, and nearly all of them look visibly different because of the muscle that they've lost and the weight that they've lost. And then prior to our work, there was some kind of weak associative studies that had published that poor preoperative status was related to higher complication rates. And so all of those problems kind of came together to the study that I'll be talking about later today that we're evaluating potential solution for that. But just to look at, any cancer type, if a patient is going into cancer therapy with inadequate muscle reserves, that really can affect their mortality rate. And that's the case for any cancer type and also any body mass index. And we'll talk a little bit more about this issue of hidden sarcopenia in patients that come in obese. And there's an assumption that they may have adequate reserve, but really they don't have the muscle reserve on them. So we'll discuss that a little bit later. And then I had mentioned that one of the things that we're seeing in our evidence base is issues with cancer treatments in patients that are sarcopenia. So these that have sarcopenia. So these are some of the things that are coming out of the literature, that there's a greater risk of dose-limiting toxicity. They have to change their schedule for chemotherapy because of being sarcopenic, and then also surgical complications that I had mentioned, physical disability, shorter survival, and then recurrence happening quicker, so a shorter time to tumor progression. Next slide. So these data are from an early pilot study that we did in the bladder cancer population, where we wanted to know how many people were actually malnourished at the base before we started working with them. We had concerns that there was not a complete process at our institution to find people that were at risk for nutritional status. And what we found just by looking at the patients that we had in our research study compared to the billing data, that about a fifth of the patient population was missed. So they even though there was a system in place, it wasn't a system that was actually finding people that were moderately malnourished or severely malnourished. And we consider that a pretty significant problem, knowing that these patients were going to undergo a surgery that was highly catabolic in nature, and it's not uncommon for them to lose like 20 or 30 pounds after the procedure. So this was something that led to a lot of conversations at our institution about process and potential ways that we could change our clinical pathways so that this problem wouldn't occur. Next slide.
So we added that question for you, and we wanted to, is that me making this noise? Uh-oh, it is. How am I making it? Or Jill, I'll let you read the question.
Okay, so the question is, does your team or health record have a way to flag patients who have a change in health status? For example, a weight loss of greater than 10 pounds since last visit would result in an EMR flag.
Okay, let's see if I'm still, I don't know what's happening here. I'll call in.
Well, I know you're super great at improvising, so let me know if you need me to help.
I'll figure it out. But post any questions that you have in the chat box, or go ahead and comment on the process you use, because I think it's really helpful to see, sort of as Dr. Hamilton-Reeves was saying, if you have a process but the process doesn't work, then it's really not a very good process, right? So we have to constantly be evaluating, are we finding those at-risk patients? And if you're missing a proportion of at-risk patients, in this case that were malnourished or not quite in that severe category, that's still a important topic. And Trish Long asks about, could some of that be due to food insecurity, or when you assess them for malnutrition, what are sort of some of the most common reasons that they're malnourished?
Yeah, so we will go into some of the items that we find using our screening tool, screening and assessment tool. And you know, to address the food insecurity question, I think that is definitely an issue for lots of different reasons. Some of our patients live in rural areas where getting to food becomes more challenging for them. They might be a little bit isolated. And so really leveraging social services to look for ways to get Meals on Wheels or meal delivery or help for those patients is particularly important. Many of these surgeries are quite debilitating, so without a support structure, it's also very hard for them to feed themselves throughout this time. So we work a lot with patients as far as thinking about preparing things ahead of time, having them in your freezer. As far as screening process for food insecurity, so you know, food insecurity could mean not having enough money to get food or not having enough the ability to get the food into the house. And there are many medical systems that have a 2-question screener or a 3-question screener that then will reach out to social work and resources that are essentially like using branch logic to help those patients navigate their way and get the help that they need for those obstacles.
And Deborah brought up a good point, if you want to read that. She says that she thinks that they have a process, but you don't see it. And that's something we realized in the previous session on distress screening, that we ask these questions, but depending on the permissions that different people have, you may not actually be able to see the screener that was done. And we don't always realize that till you pose that question. So I do think that that's something that as we've talked about, we need to know, do we have a process? Who's reviewing that, double checking that, and then can the right people see that? Because frankly, you know, we put all these permissions within our electronic health record, but it may be that the social worker who would like to see that isn't able based on the permissions. So I think that's a thing that we hadn't really thought about until 2 sessions ago when we were like, wow, we can't even see the distress screener in. So I don't know if we can actually see the nutrition screener. So these are questions that we should all be asking.
Yeah, it's a classic case of message sent is not the message received. And, you know, assumptions that the flags are catching things when the communication across the team is just so critical to keep patients from falling through the cracks.
Absolutely.
Yeah. Okay, next slide. Okay, speaking of, this is one of the tools that we use. This is a tool, so Faith Ottery is the designer behind this tool, and we work with her and a global team actually on ways that we can bring this to patients speaking lots of different languages and make sure that we find patients that are malnourished. And you can see that there's 4 boxes. This is the patient-generated side. And the reason that we find this particularly helpful is it's from the patient perspective. Sometimes clinicians get really hung up on if the information is exact. So I work with dietitians. We have a reputation of being a little bit like persnickety about things. Don't worry about it. It doesn't have to be perfect because it really is from the patient perspective as far as their interpretation of how they're doing. So that first box is about weight history. The second box is about food intake. The third box is particularly helpful for patients that have side effects or issues with eating that's related to the treatment, because you can really kind of get into those issues as far as mouth sores, things tasting funny, dysgeusia, you know, smells bothering them, all of those things that really come into play as far as a patient's appetite and willingness and ability to eat. And then the fourth box gets into the movement piece and functionality of the patient. So it asks their perception of what they're doing. And when does this happen? It's ideal if we can get a baseline status on patients and then to get longitudinal data across treatment visits. In the surgical oncology space, particularly for the surgeries that are known to be more catabolic or more invasive in nature, it's really helpful to get a preoperative nutrition status and then have routine follow-up so that, again, we can pinpoint the issues that the patients are experiencing from their perspective and help them troubleshoot, whether that is, you know, addressing some of these things like funny tasting food or noticing the weight change and trying to figure out, you know, what's going on there. And the nice thing about this particular tool is it doesn't need to be completed by a specialist. So any qualified health professional can do this. We actually partner with Faith Ottery to provide some training. It's fairly straightforward as far as doing the assessment. The back side of the sheet that we're not going to focus on much today has the metabolic factors that can play into the wasting that we might see in patients. And there's also a physical assessment that leads you to different sites where we would assess muscle and fat changes. And that doesn't play a huge part of the score, but from a clinical perspective, using that physical assessment really kind of triggers the logic and the practical aspects of what's going on with this patient and what's the best therapy to choose and how aggressive do we need to be with this patient. Next slide. All right, so I noticed that Hope put in a question about the financial toxicity that we see in patients that are fighting cancer, and you know, especially the kind of decisions they need to make regarding paying for these really expensive treatments and paying for food. And I do think that that is a large problem to which I do not have the solution for. But I know there's lots of really great brains and people living to the full to address these problems. I definitely think that that is a concern. And I know that there are people working on that. We're actually trying to recruit a new faculty member in the nutrition department that focuses on food insecurity. So hopefully she comes, because that could really expand our bandwidth here and for all of you regionally too. Okay, so going back to the slides here. So this is kind of a busy slide. What this is showing is the schema for our phase 3 clinical trial. So we have a trial that is being run through SWOG, and it's funded by the National Cancer Institute. And what we're looking at is whether using preoperative drinks and postoperative drinks that have extra ingredients in them to support the immune system are more effective at reducing complications after the surgery to remove bladder than a standard nutrition drink. And so the differences between the drinks are essentially just those 3 ingredients. The one that we call immunonutrition has extra omega-3 fatty acids, arginine, which is an amino acid, a building block of protein, and then dietary nucleotides. And the reason that we have this large study is that we had done a pilot study and shown that in a small sample of patients that were randomized, the immunonutrition reduced complication rates, reduced infection rates, and significantly changed the immune response and inflammation response in patients that took the immunonutrition drink. So, so yeah, it's a large trial. We're enrolling 200 patients. Next slide. I think that tells you a little bit more about, yeah, our objective. So 200 patients, and the primary aim of our trial is to look at the rates of postoperative complications. Remember, this is the surgery I was telling you, 2 out of every 3 patients have a complication. So we're really hoping we can move the needle on that. And then we're looking at secondary outcomes, clinical outcomes as well, such as infection rates, late effects, skeletal muscle wasting, readmission rates, complications, quality of life, and then disease-free survival and overall survival. And then our last objective is looking at the science behind this, as far as looking at the immune response. We look at different immune cell populations, cytokines, which are a biomarker of the inflammatory response. And then we're also looking at nutrition profiles. So the balance of amino acids and fatty acids that we think are playing a key role in either preserving or facilitating the wasting that we see after this surgery. Next slide. So this is one of our participants. This is the identified information from one of our participants in the phase 3 trial. And this is the participant's data at baseline. And so if you look at his front page, his worksheet, his weight has decreased a little bit, but not too badly. And his food intake is pretty much the same. He has no problems eating, and his activity and function normal with no limitations. And on this slide, you can see the back side of the sheet. So this is essentially how you score the worksheet. So the first part is looking at the % weight loss. The second is looking at disease states that can affect how quickly people waste away or their risk for wasting. And then we look at metabolic factors such as fevers, drug use, like steroids, medications is really what I mean. And then that physical exam that I was telling you about is worksheet 4, where you look at the patient and look at different sites that essentially give you an idea of muscle stores, and then you look at fat stores and fluid status. The fluid status can give you a good indication as far as protein intake, because when people are low in protein, many times they'll have some edema. It can be related to other factors as well, so that's where clinical judgment plays a role. And then what you can see is this person's rating is A, which means that this person is well-nourished. And then there's also a numerical score, that total PGSGA score, which is a 3. And essentially, if you could read the nutritional triage recommendations, that means this person's fine. You don't really need to do much with them, just assess later, they're good. And so it's helpful when you have this information as far as thinking about resources. Many times, if centers have a dietitian devoted to their oncology population, they don't have many, and for the number of patients. And so this is a way to make sure that we spend resources wisely on patients that need it most. Next slide. So this is the same patient. This is 30 days after surgery. And this participant was extremely compliant with the drinks. And yet what you can see is that the participant did lose weight since the last visit. And they're eating less than usual. They're eating normal food, but less than the normal amount. And really the main symptom complaint is not having an appetite, which is extremely common after these high physical stress types of operations. Some of them actually even report a funny metallic taste, which normally we think of being involved with chemotherapy, but it actually happens in this particular surgery as well. And then activities and function, just not normal self, not able to get up and move around. So then we look at the second page over here to the right, and we can see that the patient did have between 5 to 10% weight loss. And also if you look at worksheet 4 in the physical exam, you see a couple of places where we notice some muscle loss. And so this patient moved into a moderately malnourished category. And so it's really just showing you that this is kind of the natural course of what happens in these patients, even with a nutritional intervention. And it's helpful to see what's going on so that you can counsel the patient and do something about it. Next slide. So what are some of the things that we do about this? So I mentor a young faculty member, and we used an app that somewhat made this like a more seamless type of process as far as triggering the team to let the team know when people went from well-nourished to malnourished, and then intervening right away with addressing those symptoms. And the really cool thing is after doing that project and trying to figure out how to coordinate all the teams, it was super complex. In the end, what we found was that if you involve the team members, you get people back to their baseline status by 30 to 90 days after the surgery. And that is completely in conflict with the natural course of the data that are out there and the evidence that even 6 months after the surgery, usually these patients don't gain their lean mass back. So some of the ideas that might help as far as addressing the muscle loss across all different cancer patients with cancer, a lot of times using a higher dose of protein, maybe up to the 2 grams per kilogram a day, which is more than what our government recommendations are for a healthy population. But it's shown to be more effective, especially in our elderly population, for keeping muscle. In the surgical population, we believe that they're experiencing a conditional amino acid deficiency, so making sure we replenish those. So that's one of the points that we have with using the immunonutrition. Fish oil is really important for more of an anti-inflammatory type of response, which is going to help decrease some of the catabolism that's driven by inflammatory mediators such as interleukin-6 and TNF-alpha. And then there's some data suggesting that vitamin D can play a role in muscle strength and function. And so that's some interesting things that are coming out, and particularly when we're thinking about an elderly population that may not be getting much sunlight in the summer months when we can produce vitamin D. And then even if you stood outside naked between November and April, you cannot produce enough vitamin D. So you need to supplement during those times. So those are things to consider when you're working with your patients. And then thinking about all the different specialties that are on here. So there's so many other issues that affect intake. So we talked about food insecurity. I mentioned dentition, social factors, taste changes. There's really so many others. And that's really where, communication across the team is critically important. And fortunately, we have Dr. Clark on, so she can talk about some of the prehabilitation and strength training regimens. And, it really is lifestyle approaches, and there's not any one supplement that is going to likely be the magic bullet here. Next slide. So just in summary, if the take-home message is to learn more about the nutritional screening and assessment processes at your institution. Consider ways that you can integrate that prior to treatment, during treatment, after treatment. The tool that I mentioned takes less than 5 minutes to complete. We actually are going to be doing that assessment virtually for our phase 3 trial, given the COVID and not wanting to have physical closeness and needing social distance. And we have ways that we can do that through video conferencing. So if you think about doing that at your center, or even using pictures and talking with them over the phone. And I know we'll be offering some webinars and things to help people think through those. And keeping in mind that our oncology patients lose muscle mass and lean tissue, and the fat mass may remain stable. So sometimes it's hidden. And so really thinking about those patients that are still at risk. It's important to consider the quality of life of these patients, and without proper fuel, it's really hard for them to recover. And it takes a whole army of people. It really is about the community and communication across the multidisciplinary team. And physical therapists and cancer rehab are critically important. Leveraging a dietitian's knowledge, speech language pathologist for issues with swallowing, social worker for food insecurity and getting resources to patients, and of course psychologists as well, which can, mental health can definitely affect a person's ability to eat. And that is what I have. Any other questions or comments?
People are being shy tonight.
They're shy?
They're shy, yes.
Well, if you have any, I'll be on listening to Dr. Clark's
Great.
Yeah.
All right. Well, I mean, Dr. Clark doesn't have a whole lot more to say other than ditto. I mean, it's all of the good stuff that we know and we feel like we know, but it's some of that great research that you guys are doing that really give us the clinical oomph behind that stuff that we know in our hearts are good, right? We know good nutrition fuels good bodies. We know healthy bodies, strong bodies do better against cancer. And so I think through that kind of research, we just kind of add more steam to it. So cancer rehab and the cancer rehab part of it, I always like to take at least a second to throw in a little hay for physiatry, right? Because typically when you hear about a physiatrist, you either say what or you mispronounce psychiatry, but it is its own field. So physiatry or physical medicine and rehab, really in a nutshell, is just working with a musculoskeletal, neuromuscular deficits, and really working with certain patient populations in order to get them functionally back up to speed. So, traditionally, a lot of us do things like spinal cord injury or amputee, stroke, traumatic brain injury, even sports medicine docs, right? And while those may seem like really different areas, it's all neuromuscular functional stuff, right? And so what I tell people typically is that cancer rehab is just rehab plus, right? Because we get all of those things, and all of those things come together either premorbidly or through the poisons that we throw at them, or the surgeries that we put them through, or radiation that we zap them with. So we take all of those things and we throw all of this plus on top of it. So the idea of cancer rehab, really, in my mind, is to take all of those things and watch them and really optimize that patient as much as we can. And, the continuum that we have below, and then the next slide also, go to the next one if you want, is talking more about, when do we intervene with cancer rehab then? We come up with fancy terms for it, right? That we can do it before. So there's been a lot of talk about preventative rehabilitation, and that, exercise prevents cancer, right? All of the headlines they like to use. It probably does, right? The research is showing it probably does reduce our chances of certain types of cancer. So the importance of that, and just like we were talking about the sarcopenia, right? If someone has that reserve, if they have the ability to tolerate all of this stuff we're going to throw at them, and then heal themselves, and then get back to the activities that they want to get back to, that takes a lot. So if someone's already starting with their tank on empty, they just don't have any reserve to fall back on. The other kind of delineations that they have through this classification system is talking about restoring versus supportive versus palliative. But in my mind, that's still just talking about the personalized rehabilitation plan that we make with each patient based on where they are and where they're going and where they want to be, right? So all of those things go into play. We can go to the next slide. Thank you.
Dr. Clark, we added in a question here just so we can kind of see, have people identified or used a process kind of like you just talked about for prehabilitation? If you want to put that in the chat box, if you have, and what type of patients really are those that you're identifying, and whether you've sent them or not, who would you like to send? Because I think that people kind of don't know, like you said, if they don't have any, if they start with a deficit, what do they do? How do they get to you, and how, what's that look like?
Right.
Does insurance pay for it too? Yeah.
Yes, usually. As much as insurance ever pays for anything, right? They're so easy to work with. We don't have any insurance people on there, I guess. The hard part is the when, right? And it's never too early, because I think what we forget a lot of times in this patient population is that all of these people are coming to us with some sort of comorbid medical condition, right? They're not coming to us in a bubble. They've got rotator cuff injuries. They've got a bad back. They've got a bum knee. And so we're not going to help that along the way, right? When we make them weaker or we put them down in bed for a good long while, none of those pre-existing conditions are going to improve, right? They're all going to get a little bit worse. We're going to inflame them a little bit more with the chemotherapy. They're going to get a little achier with all of their treatments. So yeah, some of the things, if we can address them a little bit earlier, it maybe keeps them up and moving a little bit better.
And so in the chat box, we have a couple responses where some say, they don't do it in the practice, but they should. Molly has the ideal where she gets to see every patient who's getting chemo or radiation.
the
Some
dream.
see them after. So it really kind of is across the board. And Denise has is highlighting the Live Well program. I like that. So you're seeing kind of across the board. So how do we standardize that? And we can go back to kind of your slide, because your next visual, I think, helps us with that. But it's really hard to standardize this type of practice. And what would you recommend?
It is, and it's also hard because each patient is different, right? I mean, not only is each patient and each journey that they're going through different, but also their openness to it is different, or, you know, what they consider to be worthwhile, you know, for their rehab, because it's all got to be individualized to, if you can, to what their interests are and what they want to do.
Right.
But the other part that I think is hard is that the symptoms that come up through this journey are also different, right? You know, these are some of those symptoms that I listed just because they're the most frequent, right? These are the ones that keep people from doing what it is that they want to do, or the, you know, kind of generalities of what they want to do. But these can come at any point in this chain, right? I mean, people have the mood disorders and the fatigue at the time of diagnosis, right? Because that can cause the depression, or it causes, then with the depression causes the, you know, fatigue, which then leads to weakness, you know, or our treatments then lead to all of these things. So it happens at any point in the cycle. I think it's typical. And when someone was mentioning that they saw a lot of this after treatment, I think that's our knee-jerk response, right? We radiate someone, especially we've got head and neck people on here, right? There are a lot of important things between here and here, right? And they all get kind of hit with our treatments that we've got. And so people come out and they've got, you know, spinal injuries and myelopathies. They've got this, you know, cervical dystonia with all of this fibrosis through the musculature here. They end up with trismus, or, you know, Furch-Spite syndrome, or, you know, whatever the complications. And so there are a lot of those people that we see after the fact, after we've gotten done playing with them. And, you know, it's not all as easy as I hurt here and we can fix it, right? There are the ups and downs through this whole process. You know, not only between the identification and getting people to the right place, but where is the right place to get them? And so, you know, these are just some of the things that we see. I think probably the next slide, as we look at time, I think the next slide explains it a little bit better, or visually, I think I understand that better, right? Because when we think of someone who comes in and we think of a typical injury, right? A rotator cuff injury. All right, they messed up the rotator cuff, they had the event, and then we rehab them, and we expect them to get better. Okay, well now here we are with cancer, and they come in and they've got, you know, fibrosis. So they're fibrosed, breast cancer patient, they're fibrosed all in through here, and then they're gonna go and get their flap, right? So, you know, so we start getting a little bit better from where we are, and then they go get another surgery. And then we start getting a little bit better from where they are, and then there's a recurrence, and they've got to, you know, go through more chemo. So we end up with sort of this seesaw pattern because there's no definite or assured recovery course through this process. So I think that's what makes it more fun. I don't know, maybe that's morbid of me, but it makes it that really individualized care, because each person, depending on what they're coming in with and what future treatments they're getting, and, you know, where they were before all of this started and where they want to be, it's going to change your goals and change your course through the process. So I think that's the fun part of cancer rehab, is that it's very individualized. So it's hard to have that standardized. I mean, that gets back to the question. It's hard to have that standardized process because not everyone fits in a nice uniform line.
And I think your next slide talks a little bit about that, also about who actually gets access, which I think is important too.
It is, and also the comment, it's why it's so important to follow people into survivorship, continue into survivorship, right, forever. Because all of these things and the disabilities that we leave people with, we don't know how long they last, right? I mean, we're just now getting to the point that people are surviving their cancers, which is amazing and wonderful. But what are we leaving them with? I don't know. We're kind of finding out, you know, how long does does the fibrosis from radiation, how long does that build and continue? 5 years? 10 years? Forever? I don't know. We're just now getting to the point where people are surviving this huge dose of radiation we're giving them, and we're kind of figuring that out. So I completely agree with these. Therapy continues forever after this journey. And the hard part is
driving the need for, you know, the someone maybe lived through their disease, but they never lived through the late and long-term effects. So that need for constant assessment and intervention will always be there.
It will. It will. For a lot of these things, you know, this was a study they had done, and they just looked at what I consider real low-hanging fruit of assessment for who needs therapies, right? That if someone has lymphedema, you know, that's one we're fairly good at identifying and addressing early. With incontinence, so they're talking about, these were more of the GYN cancers they were looking, musculoskeletal issues, so this was pain and dysfunction, pain in general, and then mobility issues, you know, are they not getting up around and walking? And on chart review, they saw 65% of this patient population identified one of these needs, and 12% got some sort of therapy with it, right? So I do think things are changing. I think that we are getting away from the, well, it's just your new normal, right? We're getting away from that idea that what you're getting, this is cancer treatment, so you're going to have problems that come from it, right? We're starting to kind of move away from that and realize that we can intervene, we can make a difference, not only in your function, but then also the rest of your life and survivorship.
And I think what you guys have both highlighted tonight, and I want to leave a few minutes just in case somebody has questions, and I know people have to jump off if it's time, is this need for the multidisciplinary personalized approach, but the comorbid conditions really do complicate things, and who's ultimately the locus of control. So Dr. Clark, you're only going to get someone if we refer them to you. So, you know, I think this really identifies this need for that comprehensive, yes, we put the patient in the middle, but the patient isn't always equipped to say, I think I need to go to the physiatrist and the cancer rehab specialist. So it's our job as cancer care teams to really think about that process. And a 5-minute screener that you just saw that's in the toolbox, that could be a process that leads to billable service. So when we start telling the story, it starts filling in the gaps, and ultimately it's the better thing for the patient. So when you see, you know, and I know we're keeping a couple of you, but hang tight if you can, but when you see these patients in clinic, where do they usually come from? Are they self-referrals or are they provider referrals?
For me, it's typically provider referrals. You know, it's the radiation oncologist who ends up having a breast cancer patient who can't get contorted back to do the rest of her radiation therapy because her shoulder doesn't move like that anymore after surgery. No one addressed her shoulder mobility, so we can't continue treating. Because
are you the cleanup crew then? Are you kind of cleaning things up, or you know, or do you get some people who are less, you know, can they just sort of move it, or they literally can't go all the way back?
It depends. I mean, there of course is variability between all of that, but you know, I think we still right now are in a lot of the, you know, safety net. We're just here to kind of catch things as they're falling through the cracks, and we're just kind of playing cleanup. I think, you know, like we saw, someone's got, you know, if you're going to have chemo and radiation, you come see therapy. Yeah, I mean, that's the goal, right? Is you at least want someone to have that lifeline to be able to touch base and say, we want every patient to be their own advocate. And so you want them to have the resources so that if something comes up, they can say, I know who to go to.
Right.
But we know not every patient is going to be able to do that. So I think a mix is a realistic ideal of it, you know, that the patients recognize their own limitations, and then the providers are picking up on limitations through the journey.
Right. Well, I appreciate you guys for hanging tight, and I appreciate the time of Drs. Clark and Hamilton Reeves. If you guys want to stay on and ask any other questions, you have really great experts here, and take advantage of that. We want to thank you guys for participating. I forgot to update this. Next month is cancer screening. Like, how do we triage and get patients back into cancer screenings, both those who have been delayed in their screenings and cancer survivors. So any other questions as we end tonight before we thank you? And thanks, Denise, for staying. And yes, this was very informative. Any other questions, comments before we leave everyone tonight to go enjoy their sunny evening?
Be sure to check out the toolbox.
Yes. The toolbox will have all these great things. And Dr. Clark, if you have anything you want us to add, which are additional assessments, I know we have the nutritional screen, we'll have the article. So anything else that you think would be helpful, we'll put that in for the participants.
That'd be great.
Great. All right. All right. Well, thank you all, and be safe. And don't forget to secure your credits so that you can get your CEs for participation. And have a good night. Thank you, guys. Bye.
Bye. Thank you.